All right, good morning. We are here today to discuss ADHD. ADHD is Attention Deficit Hyperactivity Disorder. This is the most common neurobiological disorder of childhood and can profoundly affect the academic achievement, well-being, social interaction of children and adolescents. Unfortunately, 6 million children go undiagnosed, have been diagnosed with ADHD, and a large proportion of children go undiagnosed every year. Today we are here to emphasize the need for accurate identification of ADHD signs and symptoms, to prevent misdiagnosis of this disorder, and to improve the overall quality of care for pediatric patients. Now let's go into some of the background of ADHD. The clinical definition is that ADHD is a chronic condition that includes a combination of persistent problems, namely difficulty sustaining attention, hyperactivity, and impulsive behavior. Now, throughout the last few centuries, there have been historical descriptions of characters or children consistent with modern ADHD symptoms. These symptoms include inattention, hyperactivity, and impulsivity. Authors have been writing about these for the last 200 years, but only in the last century or so have we taken the clinical characterizations, the underlying concepts, and added nomenclature for these dysfunctions. Some of these names that we've chosen include a deficit of moral control in 1907, a post-encephalitic behavioral disorder in 1920, and a hyperkinetic disease of infancy. One of the first doctors to treat hyperactivity was Dr. Charles Bradley, and finally ADHD was codified into the DSM-3 in 1987 and has been there for the last couple revisions. Moving on to some common knowledge about ADHD. The public knows about ADHD, but unfortunately there has been some lacking information and misperceptions about the severity and prevalence of the disorder. One 2008 study by McLeod showed that only 2/3 of American adults had heard of the condition ADHD. One common public perception is that Ritalin is a medication used to treat ADHD, and the public knows that generally if your child gets ADHD, you want to treat it with medication. Unfortunately, however, there are some critics that charge that ADHD is not a real disease, but rather a collection of behaviors that parents and schools have become unwilling or unable to tolerate. These sorts of conceptions are dangerous and counterproductive for the appropriate treatment and diagnosis of children who really have this disorder. Now, what is the issue? The issue is that this disorder, ADHD, is the most prevalent neurological disease of childhood, with over 5% of children and up to 11% of children affected. And these symptoms can continue into adulthood in more than 3/4 of cases. So this is an issue not just for young patients, but for old. The importance for us is that without identification and proper treatment, ADHD can have very severe consequences. These can include school failure, family stress and disruption, depression, problems with relationships, substance abuse, injuries, and even job failure. That's why early identification and treatment is crucial for this. Now, this is why we are here to inform you about 3 things: the signs and symptoms of ADHD, the effects of overdiagnosis and misdiagnosis with current protocols, and some alternative diagnostic techniques that have arisen for ADHD.
So Daniel just went over and introduced different aspects of ADHD. I will now go over the different signs, symptoms, and physiological pathologies behind the disease. So first, we have the signs and symptoms of ADHD. Because of its twofold nature, ADHD is associated with 2 subsets of characteristics, which are inattention and hyperactivity and impulsivity. For the inattention aspect, patients may present with a variety of behaviors. These include the following: frequent carelessness in schoolwork, difficulty in focusing, organizing, and completing tasks, forgetfulness, distracted easily, avoiding mental effort, and refraining from listening to when spoken to directly. The hyperactivity/impulsivity component is attributed with another set of behaviors. Mainly, these include frequent fidgeting and restlessness, inability to participate in leisure activities, excessive talking, inability to wait one's turn, and interjecting and interrupting. For both of these categories, patients must exhibit 5 to 6 of them depending on the age range, and they must persist for over 6 months. In addition, they must be present in more than one setting and typically have detrimental impacts on interpersonal relationships. However, with any mental disorder, physicians and scientists alike find it difficult to accurately describe specific disorders. Many disorders vary between patients, and sometimes patients may only present some of the observed characteristics of the disorder. ADHD is one of these mental disorders that is further characterized and can manifest in 3 distinct ways. We're still here. If a patient presents mostly behaviors associated with hyperactivity and impulsivity, he or she exhibits predominantly hyperactive impulse presentation of ADHD. Similarly, a patient that presents with behaviors tied to inattentiveness, then he or she exhibits predominantly inattentive presentation of ADHD. However, these two groups are not mutually exclusive. A patient whose behavior aligns with both categories exhibits a combined presentation of ADHD, and therefore they exhibit both hyperactivity, impulsivity, and inattentiveness. I'll now go over the neurobiological aspect of ADHD. Physically, there's a general reduction in brain volume, specifically in the prefrontal cortex found here. The prefrontal cortex is responsible for attention and motor planning, and so is the basal ganglia, dorsal anterior cingulate cortex, corpus callosum, and cerebellum. Patients also have varied delays in cortical maturation, which means that they just take longer to reach the same level of brain activity as a healthy patient. One study even reported that gray matter took about 3 years longer to develop in ADHD patients when compared to healthy individuals, and scientists have also observed that ADHD patients that have white matter abnormalities. So, white matter is actually responsible for myelinating axons in the brain, and because this is usually what's affected when patients that have ADHD, they have lower rates of myelination of the axons, and this results in a decreased speed of neuronal activation. So this ultimately leads to dysfunction in the brain and hypoactivity in certain regions of the brain. Additionally, they also have ADHD patients also have smaller corpus callosum, which is responsible for integrating motor, cortical, and sensory processes in the brain between the two different hemispheres. So all of these together are the physiological pathologies that give rise to the actual disorder.
Alejandro just finished explaining the biological and physical signs and symptoms of ADHD. I will now tell you about the overdiagnosis and misdiagnosis of ADHD. As Daniel said earlier, ADHD is the most commonly diagnosed childhood disorder. However, there's a common perception that ADHD is vastly overdiagnosed. Both the articles I researched looked at older studies and tried to find why certain physicians and therapists diagnose children with ADHD. Scudo et al. And Ford Jones in 2007 and 2015 respectively found that ADHD was misdiagnosed but not necessarily overdiagnosed. Overdiagnosis is when the number of false positives is significantly higher than the number of false negatives. False positives are when people who are healthy are incorrectly diagnosed with ADHD, while false negatives are when people who actually have ADHD are not diagnosed. Misdiagnosis of ADHD just means that there is a high number of false positives. Possible reasons for misdiagnoses could be due to comorbidities, diagnostic inaccuracies, gender differences, and even school entry cutoff dates. Symptoms like aggressiveness, destructive behaviors, episodes of mood swings, and loss of interest in activities are all common between mental health disorders such as depression, anxiety, conduct disorder, and bipolar disorder. As you can see, this makes it very hard for psychologists and physicians to distinguish which symptoms are caused by ADHD as opposed to the other disorders. This leads me to the next reason why ADHD is misdiagnosed, and that's because of diagnostic inaccuracies. There is such a high variability in assessment procedures. Keto et al. Found that a large portion of practicing psychologists do not regularly follow assessment procedures that are consistent with the best practice guidelines. A lot of physicians relied heavily on interviews, and most did not adhere to the DSM criteria or use standardized assessment tools. Another reason for ADHD misdiagnosis is gender differences. The male to female prevalence ratio of ADHD is 6:1. Boys are more likely to get diagnosed with ADHD because they are generally more active and hyper than girls, which contributes to the significant increase in false positives. On the other hand, girls are more likely to show greater intellectual impairment and other internal symptoms of ADHD compared to boys, which contribute to the few false negatives we get in ADHD diagnosis. And lastly, children who are born right before the school entry cutoff date experience higher rates of ADHD. These kids are younger than their fellow peers and therefore most likely less mature. Because they are less mature than the rest, their educator usually requests them to be assessed for ADHD, which is how more than half the cases get diagnosed. The difficulties in debating whether a child should be diagnosed is that sometimes the ADHD signs are normal for the children's developmental age, but it's difficult to distinguish the majority of kids whose symptoms will pass and the few who will develop persistent ADHD. I have just explained why ADHD is not overdiagnosed, but the possible reasons why it is vastly misdiagnosed.
As we've explained, diagnosing ADHD is a common problem due to various factors that lead to misdiagnosis and overtreatment. Therefore, we wanted to research alternative diagnostic measures that can improve efficacy and accuracy of ADHD diagnosing. First, I'm going to talk about computerized diagnostic techniques. The QB test, which stands for Quantitative Behavioral Test, incorporates a cognitive test, aka the Continuous Performance Test, and a motion tracking system. The CPT measures impulsivity and attentiveness, while the motion tracking system measures hyperactivity while taking the test. This picture shows the setup of a QB test. A study by Hall et al. In 2017 found that 100% of clinicians felt more confident in their diagnosis when using the QB test. They also felt as if they had a better grasp on the specific ADHD symptoms of their patient. 48% of families said that the QB test's objectivity helped them recognize the symptoms in their children. 46% of the families stated that the QB test helped them understand the diagnosis, and 39% of the families said that the QB test helped them understand the chosen medications used to treat the ADHD. The other computerized diagnostic technique is the Computer Clinical Decision Support System, or CDSS. This system uses the patient's electronic medical record along with patient information obtained from observations and parental reports to evaluate each patient on a case-by-case basis and provide individualized clinical parameters. These guidelines are based on carelessness, inability to remain seated, and inattention. An increase of 31% was seen in the percentage of clinicians to follow clinical guidelines in ADHD diagnosis, treatment, and follow-up in a study by Carroll et al. In 2013. The follow-up included adjusting medications and referrals to specialists. The percentage of clinicians following clinical guidelines in the control group, which did not have access to the ADHD module, decreased by 22%. Electroencephalograms, or EEGs, can be used to determine differences in brain function between people with ADHD and people without ADHD. A study by Chen et al. In 2019 found that delta power was significantly higher in children with ADHD, while alpha and beta 1 groups were significantly lower. This data can be used to diagnose ADHD without relying on behavioral abnormalities, which removes bias from observers and could improve accuracy in regards to diagnosing ADHD, while also explaining the physiological aspects of the disorder. The final alternative diagnostic technique is the cognitive assessment system, specifically the planning, attention, simultaneous, and successive theory, or PATH section. This incorporated 3 levels of evaluations. The first one being parent interviews using structured diagnostic interviews. the second being teacher reports using the ASCA and Learning Behavior Scale, and the third being students' own reports using the CAS itself. With all of these reports working together, researchers in a study by Kavnivas and et al. In 2016 were able to correctly classify 77.5% of the participants of having ADHD. This same study showed the control group scoring 17.05 points higher than average on the attention section of the CAS in school, and the control group had a mean score that is 12.5 points higher than the ADHD group on the planning section of the CAS. Overall, these alternative diagnostic methods should not necessarily replace traditional methods, but should be used in conjunction with typical DSM and observational techniques.
So overall, we just informed you about the signs and symptoms of ADHD, the overdiagnosis and misdiagnosis with current protocols, and some alternative diagnostic techniques for ADHD. With a significant percentage of children affected, ADHD is a prevalent condition that causes difficulties in concentration and frequent periods of hyperactivity. In addition to behavioral symptoms, differences in neurological features can be observed to provide an accurate diagnosis. According to a Michigan State University researcher, nearly 1 million children in the United States are potentially misdiagnosed with ADHD due to inaccuracies in traditional diagnostic techniques and other erroneous measures. Consequently, children receive inappropriate treatment. In order to improve the rate of misdiagnosis, alternative diagnostic measures do exist that can provide effective evaluations and ultimately allow all those affected to reach their full potential. Now, I want you all to imagine being misdiagnosed with ADHD and taking a medication that impacts your self-image when that intervention was not necessary. People treat you differently, ranging from bullying at school to receiving unwarranted extra attention because of this misdiagnosis. In addition, you are subject to the stigmas associated with the disorder and the side effects brought about by your unnecessary medication. Hopefully, parents, educators, and physicians in today's society can prevent these instances from occurring again. Now, I will present a case study of a boy with a possible diagnosis of ADHD. This is Thiago. He is 5 years old, and he lives with his single mother. They visit a physician's office in order to discuss his recurrent aggressive episodes with other kids in the playground and struggles with schoolwork, causing him to fall behind in several subjects. Since the beginning of the school year, about 5 months ago, he has continuously worsened, causing him to have difficulties in joining friend groups. Also, Thiago is usually impatient and cannot concentrate for long periods of time. It is rare for him to sit through an entire movie without fidgeting and interrupting. His mom is very worried about his poor academic performance and greatly concerned about his inability to interact with other kids his age. Now with your devices, you can answer the questions posted.